Welcome everyone to Cornell Keynotes. I want to thank you for joining us today. Today we're going to look at how hospitals, clinics, and community systems interact and how they sometimes and quite often fail to do so. You know, many of us in the U.S. have experienced this firsthand. What does it look like? Miscommunications, duplication of services, sometimes mind-boggling gaps, which are throwing up barriers to patient care everywhere. And of course, this impacts healthcare outcomes and even healthcare access. So while the goal is seamless, patient-centered care, inefficiencies often get in the way. So we're going to look at what works well, what doesn't, and how we might rethink our system so that it supports patients from start to finish in a seamless journey. To that end, we've got, once again, Dr. Nick Fabrizio in the studio today, who's joining us from the Cornell Brooks School of Public Policy. Nick, great to have you back in today.
Chris, thanks for having me. It's great to be here.
Yeah, you bet. Nick and I have done this before. We're excited to be presenting this in front of a new audience, so I want to welcome you all as well. I should mention that we are going to take your questions throughout, so simply drop them in the chat when you see fit, and we'll try to take them. I've got them on my iPad here. So Nick, you're faculty author of online courses in a program that's done in partnership, Cornell did in partnership with the Brooks School of Public Policy at Cornell. The program is called the Executive Masters of Health Administration. I should mention to our audience that a lot of what we're going to be covering today maps to what you teach within those courses for healthcare leaders, aspiring healthcare leaders, et cetera. In addition to teaching students at the Brooks School, can you tell us about your experience in the healthcare industry and how it translates into your teaching at Cornell?
Absolutely. So I've been teaching at Cornell for 25 years now, and for 20 years, just over 20 years, I was a healthcare consultant. So I was actively in the field. I've worked in 50 states. I worked with hospitals, health systems, medical group practices, did a lot of mergers and acquisitions, strategic planning, and workflow assessments. So it's been a great learning lab to have a practice where I consulted nationally and also be able to teach at Cornell with students.
So let's get right into the heart of the matter here, which is we're going to be talking about optimal patient care. We're going to be identifying all the problems, looking at ways we can fix them. What does the optimal care and coordination journey look like for a patient?
Great. So from a patient's perspective, care coordination looks like care that is reliable, seamless, nearly invisible. It should be one continuous patient story. Patients should not have to repeat at every visit their medical history, their medications, prior diagnoses, and care plans. Information should travel with the patient. It should also be connected across the care system. Care coordination should link the primary care providers with specialists, with hospitals, and also with post-acute care. Every provider should see the same information. It's really about real-time communication. When something changes, either a new diagnosis or a medication adjustment or test results, the entire care team should know immediately what's going on with the patient. For the patient's experience, when coordination works, healthcare feels like one coherent journey, not a series of disconnected episodes. The goal is a well-coordinated system.
Okay, so we've identified the optimal. Let's talk about some of the problems that we experience. So, you know, speaking of disconnected episodes, where do you see the most common points of failure when hospitals, clinics, or community systems are trying to work together? Where are the gaps? Where are the breakdowns actually happening?
So the biggest breakdowns and failures occur at the handoff points, when responsibility shifts and coordination often weakens. What we need to do is focus on transitions of care. A common breakdown occurs when patients move for care from the hospital to the primary care office, from the hospital to the specialist, from the primary care office to the specialist, and even from the hospital to post-acute care. These transitions create risk. We have to uncover information gaps. Clinics and providers often receive incomplete discharge information, delayed records, limited clinical context. Critical details are often missing. The impact on this is serious for the patient. Breakdowns can lead to medication errors, missed follow-up visits, preventable hospital readmissions, and extreme cases, death. Patients feel the consequences. The real issue for clinicians is that most breakdowns are not individual failures. They're system design problems appearing in clinical practice. Better coordination requires better systems.
I think for a lot of us, just sort of bringing this up, but for our domestic audience, our United States based audience, these are familiar things. These are things that happen for those that are engaged with the systems. For international audience, can't necessarily speak to that, but we are talking about primarily the U.S. Healthcare system. And two big things that happen. A lot of us experience two things. Duplication of services. Wow, is that frustrating? And also sometimes miscommunications around that. Can you share an example of how these issues, again, miscommunication, duplication of services, can actually impact patient outcomes? What are the threats there? What are the problems that we can encounter? And even more importantly, access to care. I'm curious about how that might work or not.
Absolutely, Chris. Yeah. So a common barrier is miscommunication and duplication. When health systems don't communicate effectively, information is lost, services are repeated, and patients experience delays. So a common example of this is diagnostic testing. Patients receiving care across multiple health systems may face repeat imaging, duplicate laboratory tests, and failure to communicate medical information, often because these results are not shared or even trusted across systems. So these health records are fragmented. Different organizations often use separate electronic health record platforms, and a result of this is that test results don't transfer easily. Providers lack the full clinical context, and testing is repeated to confirm results. Providers are often unaware of what has happened to the patient, and these impact outcomes and access to care. This duplication leads to delayed diagnoses, delayed treatments, higher out-of-pocket costs, and unnecessary care. And this is especially important for patients with high deductibles or limited coverage. The patient perspective in all of this is critical. Patients should not have to pay the price for fragmented systems. They shouldn't have to pay for failures in how our health systems communicate. Better coordination means faster decisions, lower costs, and better access to care.
Okay, well, it can't be all bad news here today, Nick. Let's focus on some bright spots, for instance. When you look at care coordination, there's got to be some good examples, some gold standards, things that might be working well. Are there particular regions, health systems, or healthcare delivery models, care coordination models that are actually working well, and can we capitalize on them?
Absolutely. So while challenges remain, some health systems are building stronger coordination models. Many improvements come from intentional systems design. It's really about building coordinated infrastructure. Leading systems are created dedicated care coordination programs that are designed to manage patient transitions and follow-up care. Coordination is treated as a core operational function, not an afterthought. So an example of this is My Michigan Health. They have launched continuing care clinics that are focused on patients transitioning from the hospital to discharge, from the emergency departments back into the communities, and oftentimes from provider to provider. These clinics provide multidisciplinary follow-up, medication reconciliation, and care plan coordination. The goal is to close the gap between acute and outpatient care. The impact of all this is when coordination infrastructure is intentional, we have avoidable readmissions, patients experience smoother transitions of care, and health systems improve the continuity of care. Care becomes more connected and reliable. It's effective care. It doesn't happen by accident. It happens when organizations design systems to support it.
So maybe continuing care clinics is something that we're going to hopefully see some more of in the near term. Sorry, I got to check my thing here. I should check with our audience really quickly and mention once again that we are taking your questions throughout. So if you want to submit them, do that in the chat. A couple other notable things. We're going to share some URLs that are useful resources for you. So again, the Executive Masters of Healthcare Administration is something you should check out because it covers a lot of the issues that we are speaking here. All right, let's start to pull out a little bit. We're going to go a little bit higher level, thinking about the policy perspective, way up there. Are there like critical structural or systemic issues rather that make seamless care coordination so challenging? Is there something that's baked into the cake that creates this level of dysfunction within our systems?
Well, certainly. What? I think from a policy perspective, it's really data and interoperability. Mm-hmm. Care coordination depends on information moving across systems. but many healthcare organizations still can't exchange data easily, or for that matter, in real time. We've made some progress, but certainly not enough. Federal policy has made progress by promoting health information sharing, data security and privacy, and interoperability standards, but practical barriers still remain. Think of this. Think of availability versus usability. Policies focus largely on data availability, but clinicians need data usability. They need complete information, timely access, and integration into clinical workflows. We certainly have fragmented technology systems today. Healthcare providers often use different electronic health records. It creates challenges using multiple platforms, having separate logins and passwords, and having limited real-time coordination. Can I tell you the story about what's happened to my father recently?
You mentioned this in our pre-game huddle. Your father's 88. What was his experience recently?
So in the last couple of months, my dad had a sore foot. So I said, why don't you go see your primary care provider? So he went to his primary care provider. His primary care looked at his foot. It was infected. Sent him to wound care. The wound care folks looked at his foot, decided he needed to be admitted to the hospital. So he went to the hospital.
Because it was an emergency.
It was an emergency.
Okay.
He went to the hospital and stayed there for 4 days until his infection cleared up and he was discharged. Now, they also suggested that he see a vascular surgeon. So we made an appointment with a vascular surgeon who needed to perform an angiogram in a different hospital.
What's an angiogram?
An angiogram is where they look to see what the blood flow, essentially what the blood flow was like. And
Okay.
he unfortunately has a poor blood flow in his lower leg.
Okay.
And that was one of the reasons that the infection didn't clear up in time.
Yep.
But during that journey, I had 5 different electronic health record platforms, health record systems, that I had to navigate through. I had to have a username and a password for 5 different systems, which required me, frankly, to have my iPhone and use a password manager, because there was no way, I can't remember my own username and password, and there was no way I was going to remember 5 different usernames and 5 different passwords for 5 different systems. And certainly, my 88-year-old father was not going to do that.
No chance. So what was the outcome there? Is this still ongoing, or what's going on with Dad?
Well, the outcome is he's okay now.
Good.
He's healthy.
Yeah.
But still, he has appointments with his vascular surgeon, his wound care doctor,
Yep.
and his primary care doctor.
That's exactly right.
So I still have separate usernames and passwords.
Okay, good luck through that. I have a question from user Nancy, or viewer Nancy, who asks, how much of the problem is the result of the patient not being effectively and actively involved in their own care? Okay, that's kind of a challenging one. That's a tough thing to kind of deal with, right? So as patients, we think about, let's take this user case right here. Do you think you were actively or effectively involved in the care? I mean, you working in this space, I presume so. But for a lot of patients, they might feel alone, might not take an active role, but rather a passive one, moving through the system as prescribed, right? Do you get Nancy's question here? Do you think this is a problem?
Yeah, I mean, I think it's a problem. It's certainly, I can navigate it, one, because I have time, and 2, because I've been in healthcare for 25 years.
Yeah.
So it gives me, an advantage. But I think for the regular person out there who's not in the healthcare field, this is a daunting task. I can't imagine maybe being in another state or being away from your parents or a loved one and having to manage their care. It's nearly impossible. It's hard enough for me to do, let alone for a loved one. And again, this could be not only your parents, but it could be your children. So once you leave, as I say, once you leave home base and you're in another healthcare system, it's really difficult to manage this. When I think back, I remember the days when we had paper charts. And I think how much more advanced are we now with electronic health records than paper charts? And I can't say that it's a whole lot more efficient. And I think that's a sad commentary.
Right, and for a lot of us who are in the patient experience, whether it be with our relatives or ourselves, do we need to be that actively involved? I mean, that doesn't feel like a seamless patient experience, right? Kind of the opposite.
Yeah, I mean, I think we have to be involved, because in the
Yes.
absence of that, what choice do we have?
That's right.
I mean, I'm thinking in my scenario, my dad would just be floundering in care. I think we would have had a worse outcome than we actually had. So I really had to be involved in that.
Yeah.
But in a lot of situations, people can't be that involved.
Yeah, so we're wrapping up that policy question, and thanks, Nancy, for that kind of related question. Oh, here we go. We got a little tool switcheroo here, just dealing with our tech. Thanks for the question, Nancy. Anybody else has questions? Of course, we'll take them here. So let's get reset. We're at number 6 here, Nick.
Okay.
And this is what we're going to be talking about. Are there any tech innovations or new tools that can strengthen the connections across the healthcare continuum? It sounds like there's no shortage of tech and tools. Anything that we can point to that shows some promise? I know there's telehealth platforms and things along those lines.
Well, we certainly have to think of the continuity of care and having more connected systems. So the two areas that show really promise are connected health platforms and AI and predictive analysis. So really moving to connected health, connected health and telehealth, we need modern platforms that go simply beyond video visits. They integrate remote patient monitoring, asynchronous communication, and continuous patient engagement. We have to have care teams that stay connected with the patient. And a priority of this is, frankly, chronic disease management. We have to have connected care that deals with the most vulnerable populations and the most vulnerable conditions. That's heart failure, diabetes, and COPD. This real-time monitoring and frequent check-ins can detect issues earlier and prevent hospitalizations. AI and predictive analysis analytics is really the new frontier. So we have to have advanced analytics that help systems identify and track high-risk patients. We need to look at data earlier in the intervention process, and anticipate complications and support proactive care. But we have to make data work for clinicians. It's really promising. Innovation is fantastic, but we have to do more with visits and integrating technology into the clinical workflow. Technology should reduce administrative burden so clinicians can focus on patient care.
I have a couple of really good questions that are coming in from the audience. You mind if we take those now, Nick?
Absolutely.
Okay, good. We have one from Mary Ann who asks, do you think patient-controlled health records, where patients keep their medical information in one secure place and providers can access it when needed, do you think this could help reduce duplicated tests and improve communication between specialists? Sounds to me like it could, but maybe, I don't know.
No, absolutely. I think whatever we can do to improve communication and also help that real-time communication, and it's really, as we talked about earlier, it's the interoperability, and it's really being able to follow that patient throughout their episode of care. So my dad's example again, it happens, it shows itself continuously. When you go from your primary care provider to a specialist, having lab results, having tests, for the patients to be able to understand what's happening in that process is paramount.
Yeah, so I mean, that patient-controlled health record sounds like it could be aspirational at this point. The tech can't possibly be there, given the disparate platforms that we're dealing with, like in the case of Dad, 5 different, right? So, yeah, it sounds great. Great question, Marianne. I have another one from Joe, who asks, in my region where I live, there are now 2 large hospital systems who are acquiring the independent community-based hospitals, presumably in the same region. While mergers and acquisitions are challenging, there's still so many gaps and disconnects, and staff do not know who is responsible for what. You may have come across this kind of thing before. Morale nosedives and patients take the hit. Do you think or feel that M&As, mergers and acquisitions, are improving care coordination? Because we're seeing this everywhere. Thoughts? That's
a great question. These questions are fantastic, so please keep them coming. I think to the effect that mergers and acquisitions can bring systems together, not just systems, but providers, when they can bring them together and share a platform. So again, we'll go back to my dad's example. If the primary care provider, first of all, if we could have done this in one town, it would have been easier. The fact that we had to go from his hometown 30 miles away to major tertiary center for the care, that added complexity. But if those systems were integrated and they had one medical record platform where the primary care office, the wound care would be ideal, the specialist office, and those 2 hospitals were integrated, I could have gone from 5 different EHR systems to maybe one. So I would maybe only have to manage one username and password and one other system. So the impact that a merger and acquisition can have on communities, to the effect that it can bring them together. Now, in my days of merger and acquisitions, when we used to bring other hospitals on board, they'd still be able to use their current electronic health record for a number of years until they were truly integrated. So if it's a truly integrated healthcare system where they share the platform, that's much better for the patients.
You know, I think, speaking of patients, I'm also thinking on the other side, the healthcare leaders, the people that are aspiring to work in this space. I don't work in this space, so I don't know. But I mean, are mergers and acquisitions a constant concern among leaders? Is this something that everybody's experiencing, or half the people? I don't know. Forgive my ignorance, but mergers and acquisitions, consolidation of services, is this going on everywhere all the time?
It's certainly going on everywhere all the time. I mean, if in these communities that were once single hospital towns are now being acquired by health systems. So if they're not at least in a discussion with a merger and acquisition, they're really a unicorn. It's really getting to be the norm. These systems continue to look at other partners. So there are other creative strategies that you could remain independent and affiliated with the system. The question, though, remains, back to our topic, can you be truly integrated with a healthcare system, and can you kind of look at that care that's provided and standardize that in terms of technology platform across those disparate entities?
Okay, so the answer is, for a leader or aspiring leader, get literate in this kind of stuff.
Absolutely.
Right? Because this is absolutely critical.
Absolutely.
Speaking of literacy, so for healthcare leaders, aspiring leaders, can you offer us a few practical strategies, or even to give us sort of mindset guidance on how we can move toward a better patient-centered care type scenario?
Absolutely.
Or reality.
Absolutely. So improving care coordination requires a real focus on two key areas. They stand out. The first strategy is strengthening care transitions. You have to invest in structured handoffs, especially at hospital discharge. You need a clear ownership of follow-up, standardized discharge summaries, medication reconciliation, and scheduled post-discharge appointments. The goal is to reduce patient confusion and ensure continuity. From the patient's perspective, during these transitions, patients are most vulnerable. There need to be structured processes that make care feel seamless and reliable and improve outcomes and experience. The second strategy is multidisciplinary care teams. We need to build teams around high-risk patients. We need to involve care managers, nurses, pharmacists, and social workers. These teams work alongside physicians to coordinate complex care effectively. The impact of this is a deliberate focus on enhancing continuity of care, reducing errors and readmissions, and connecting systems. It's teams plus transitions equal better outcomes.
Very good. I have a question from Amro here that's a little bit of a specific use case, but I'm curious what you think of this. One doctor suggested I should stop an injection, but the next doctor suggested I should continue with it. It really is troublesome. How do you navigate multiple opinions on your care? So again, another terrible pinch point for the patient. But are we allowed within our system the flexibility to make choices like Amro would like to be able to make? Second opinions.
That's a great question, and it's a common question. And I'll go back to my dad's care, and in my dad's example, we had conflicting messages of what to do with his foot infection, which sounds like you're getting conflicting messages too. But we are certainly entitled to second opinions and even third opinions. So if you don't like the answer you heard and you're conflicted between the first opinion and the second opinion, you should reach out and get a third opinion. Maybe it's what the first person said, maybe it's what the second person said, maybe it's a third totally different opinion, but you certainly have to have a right to seek out another opinion.
Now, will this create more miscommunication, bad handoffs, not the opposite of seamless kind of care? Will it further complicate Amro's patient journey?
It certainly could, because in that example that I gave with bringing a third person in, you could have yet a third patient portal, right? So you could have 3 usernames, 3 passwords, and 3 different portals to navigate through. And depending on where they send you and what specialist you go to, you add in that complexity.
Yeah, right. Not making light of any medical situations, but the prospect of another patient portal is horrifying enough.
Absolutely.
We've all been through it. Okay, let's pull out to even higher elevation and think even bigger. So looking ahead, do you think we need to re-engineer or rebuild our healthcare system from start to finish in order to fix some of these problems?
Well, I think we certainly need to keep rethinking healthcare. We have to move from isolated visits, we still have today, to a continuous relationship with patients. Care should be longitudinal and not specific. The goal really is longitudinal accountability. The system must take responsibility for keeping patients healthy, preventing crisis and errors, achieving outcomes that matter to them. Payment and performance models have to reward continuity, prevention, and coordination. We really need a patient-centered design. Healthcare needs to follow patients across the home, the clinic, the doctor's offices, the hospitals, and their communities. We need to use flexible care teams. Virtual care, local partnerships, they all help to reduce handoffs and improve communication. Think of data as a coordinated infrastructure. Data and technology must be timely and usable, integrated into clinical workflows, and accessible and controlled by patients. Interoperability alone is certainly not enough. The future of healthcare requires change. A truly patient-centered system requires continuity over the episodes of care that we discussed earlier. Care should be designed around the patient's lives, and technology should enable action and not just be a form of documentation. When we get this right, healthcare becomes a seamless journey, not a series of visits.
So the through line, the message is crystal clear. Thanks for bringing it to us today. And we know what it's all about. We know what we must do. But sit tight for one more moment because we got a doozy from Urbane who asked a question.
Great.
This is a tough one.
Excellent.
When it comes to care coordination, interoperability and data usability, isn't the challenge that no single facility truly owns the problem? From a financial perspective, which we do have to be realistic about, there's no direct ROI for any individual organization. I want you to set us up on whether or not that's an incorrect or a correct assumption there, presumption. Do you agree, Nick? And if that's the case, does it mean policy or government action is the only real solution? You get what's going on here?
Absolutely.
Yeah.
Absolutely. And I think, if I read between the lines into that excellent question, I think there has to be some kind of a government intervention. Otherwise, we're going to continue with this fragmented system. Yeah. We're really not making monumental changes or improvements to the system. As we discussed, having 5 different platforms, EHR systems along the patient journey that happens within 2 or 3 weeks is insane. Yep. That we still have to go through that. Now, from an ROI standpoint, that's an interesting question because you're right. A lot of systems look at ROI and think of ROI. But then on the other hand, why is it then that every time we leave a healthcare provider's office or a hospital, we get that patient survey? So hospitals are still relying very heavily on patient surveys for whatever that means to them. It may or may not be connected to the ROI, but it's certainly connected to their experience and their feeling about that total healthcare journey that they're on. Mm-hmm. So I think if we can connect those dots, we certainly have to expand what ROI means. It can't just be a financial analysis. We have to integrate what we're getting in these comments from our patients because we're asking our patients all the time to comment on the care that they received every step along the way. We're just not making that connection and relating that to the ROI, which I think is to the heart of that excellent question.
Perfect. Thanks, Urbane, for that question. I've got one more from Kevin. Sure. What are your thoughts on how insurance companies help or hurt patient care? Our facility works hard to provide seamless health care to our patients, but insurance companies have a huge impact on the patient experience. How do we tackle the insurance company's responsibility with this issue? Interesting conflict we're talking about here. Do you understand the question?
Yeah, I understand the question. I think it's a great question. Again, it's what kind of intervention do we need? Do we need the government to be more involved or not? I guess it depends on who you ask. Mm-hmm. But certainly that's a challenging question. It's really a challenging issue. To make real improvements, we've got to get that accountability down. So is it at the insurance in 25 years, I've heard these arguments just around different themes. Is it the hospital's fault? Is it the insurance company's fault? Is it the patient's fault? We're always looking for whose fault it is, but those players remain. And so we continue to look for ways to make improvements with the healthcare journey. But in terms of who's at fault, I think we all own a little bit of that. But certainly we have to fix this blame game of whose blame it is. And I'm really not sure how we do that, other than getting everyone focused on the one thing that we tend to neglect. How do we make the patient experience more reliable and safer? And that's what we're going to struggle with.
Yeah, exactly. I want to thank everyone for the questions. That goes to Kevin, Urbane, Marianne, Joe, Amro had a good one. I want to thank everybody for joining us today. I should mention that the problems, the solutions, the recommendations, and a lot of the strategies that we talked about here in order to address these problems directly point and map to the coursework that's taught in the Executive Master's Program offered here at Cornell in partnership with the Cornell Brooks School of Public Policy. So for those who are interested in learning more about this, who are interested in professionally developing in this space, we're going to share some information about it in the chat. I want to thank you all for your questions. Nick Fabrizio, more than anybody, thank you for coming in the studio and talking us through this.
Thanks for having me. Love to be here. Had a great time.
Always a pleasure. Thanks everybody for joining us today. We'll see you on the next Keynote. Thank you so much.